Good afternoon also from my side. Good afternoon from Germany. I'll I'll try to give in my presentation this afternoon an overview of the trends that we see in nuclear medicine space and have been introduced the last years, and how technologies predominantly introduced by Siemens for this presentation that are addressing those trends and basically enabling them to establish their adoption. So I'll start with the SPECT-CT, and then as we go on, I will transition into PET-CT. The first and foremost trend that we have seen in the market the last 3 or more years is basically the transition from SPECT to SPECT-CT to hybrid imaging. It is interesting that about every one SPECT system that we see being in new system that we see being installed today, about 3 SPECT-CTs are also installed. And considering that the European market is basically a replacement market, it is clear that more and more SPECT systems are leaving, and the field, the applications, the hospitals, and more hybrid systems are being installed and used. But why is that? Well, first of all, there are new applications which benefit from the hybrid nature of this technology. To state one, it's the orthopedic SPECT-CT, both in relation to sport medicine as well as assessing the health of implants. Another application is, of course, the improved localization in oncology, like, for example, in the patient here above, where iodine I31 has been administered, and without the CT, we have no idea where about this blob exists in relation to the anatomy of the patient. And of course, there are the corrections that quantitative SPECT needs that requires that information. And the most important of those is, of course, attenuation correction, but others as well exist. And I will refer to them in extent later. But the most important trend that we see is the introduction of theranostics and therapeutic applications of nuclear medicine. And it is expected that several new tracers will reach the market fairly soon, and that the global revenue or business, if you wish, for nuclear medicine will basically half of it will come from these nuclear applications. That translates as well into the revenue that comes from nuclear medicine applications into the hospitals from the nuclear medicine departments. And what is the prerequisite from the technological side in order to address these applications? The first one is basically that these are traces which are highly specific because they need to address specific malignancies or tissues, disease tissues. So we need also highly specific or increased ability to localize these uptakes. Therefore, we are talking about hybrid systems, SPECT-CTs. The other need is the need for quantification. And why is that? This is because when we do the therapy assessment, when we do even therapy planning for which patients to send for those specific applications, we need the ability of the system to be quantitative. And also with a big question mark here is, of course, the dosimetry applications, whether these will be implemented finally or not to these new applications is still under debate, but nevertheless, we require a system that it is able to do the dosimetric calculations. Therefore, for the cameras, we need them to be capable and optimized for a very large span of energies and count rates, and we need to be able to do accurate, reproducible, and fast calibrations. Historically, the way that we used the information from SPECT and CT was quite abstract. So we took the CT acquisition, we utilized it for, and we still utilize it for attenuation correction, and then we correct the spec information and we reconstruct in vacuum. And at the end of this process, we fuse the anatomical with the functional information together in order to present to the reviewing physician the fused SPECT CT scan for reporting. Now, several years ago at Siemens, we took a different path, and that was when we introduced the XPECT reconstruction. This is a completely different reconstruction framework. It doesn't use MLEM. It is a different approach to reconstruction, because what we have seen is that the most important flaw of MLEM was the biases that introduce when you reconstruct low photopenic, basically, data. And apart from this, so we introduce a completely different algorithm, and it incorporates the standard corrections like attenuation and scatter correction, but we also introduced corrections like, of course, the PSF, the dead time, hardware as well as software corrections, the measurement of deflections of the gantry, and also, if applicable and where applicable, the ability to have a calibrated and quantitative outcome. The first application that we did with this new algorithm was XPECT bone. So the XPECT algorithm has also the ability to incorporate anatomical information in those cases where we know that the radiopharmaceutical that we have introduced goes to specific tissues. Like, for example, here with MDP, we do not expect to find MDP anywhere else but the bone after the uptake period. Therefore, we can utilize the CT information here not only for the attenuation correction, not only for the production of the mu maps, but also to identify the cortical and soft bone that we anticipate this reconstruction, this radiopharmaceutical to exist, to be. So with this a priori information that we feed into the reconstruction, we have some quite interesting results. Like, for example, the example that we see here, where below is the standard iterative reconstruction for Siemens, the Flash 3D, incorporating the majority of the corrections that already are available. And on top is the XPECT bone, where you see that the SPECT information has now utilized the additional info from the anatomical image and improved the spatial resolution as well as the contrast of the scan. Of the scan, excuse me. But what happens when we have metal artifacts in the CT? This obviously will affect the quantification. Will affect first of all, will affect this type of reconstructions, all the a priori reconstructions. So we have to address them before we use them into the reconstruction scheme. And this can be done with the metal artifact reduction algorithms that it's currently available on the CT systems. And once we have corrected for this, we can utilize the information freely for driving the SPECT reconstruction. Like, for example, here, where I don't know if you can see my cursor, where we have metal implants in the mouth of this patient with nasty streak artifacts from beam hardening, and after the correction for these artifacts, of course, the imposed artifacts, the generated artifacts into the from XPECT are eliminated. But we talked earlier about quantification, and I would like to address that because it's the next topic. Is it easy to implement quantification in a department today? The answer is a little bit complicated because it is easy if you have the know-how and if you have the time. Camera calibration requires several different steps, and the most important issue here is that this needs to be done at certain time intervals that needs to be in a reproducible fashion and not introduced any biases. Once this is done, then at least the Symbias have the ability to allow the calibration to be entered into the reconstruction, and it produces quantitative data, either in SUV or in Becker per ml fashion. But we've gone one step further. And what we have done is, because we would like to address the point of the manual aspect of calibration, and also the time intensiveness of it, and the increase of the potential error, we have automated this process altogether. So what basically we have done is we have created a methodology which is based on a traceable source of non-activity and non-tolerance, an algorithm as well, which takes into account not only the whole acquisition and processing of the data, and what it outputs is basically a way of calibrating the camera in an automated, fast, accurate, and standardized fashion. And this is done for the majority of today's isotopes that are currently in the field. For example, technetium, iodine 121, iodine 123, iodine 131, indium 111, lutetium 177. And this algorithm, or these two flavors of expect, can be incorporated into one application. So here you see an example of a prostate patient with metastasis at the ribs. The first scan is before treatment. The second is on 3 months after treatment and 8 months after treatment, respectively. And below is the PSA numbers as well as the SUV numbers from the two lesions, one here in the ribs and the other one here in the scapula bone. What we can say is that, well, with respect to pre and post treatment at 3 months, with naked eye, you cannot basically say whether this lesion is responding to therapy or not. Of course, after 8 months, you can clearly say that the activity is reduced, but not at 3 months. So what we can do here is we can have a view of the activity of the quantitative data, SUV, in the same way that we do it with PET, and we can see not only a reduction in PSA, but also for those specific lesions, both of them at 3 months, we are confident, or more confident at least, that they are responding. We see an effect of this treatment. Moving fasting to PET-CT in the interest of time, in order to capture the main trends in the field, I have taken an editorial article from Professor Chernin from UCLA in California, where he did a SWOT analysis of the nuclear medicine background today, and I have taken from here only the opportunities. And the main opportunities that he has identified is the rise of nuclear theranostics and the new tracers that are being introduced. With respect to the tracers, I mean, the FDA has already approved new tracers, about 9 of them. Lately, also, the Lantheus PSMA has also been approved. So 10 of the new tracers at least have been approved, which are related with PET, excluding, of course, ioflupane here. And from the area of theranostics, several tracers or several theranostic pairs have also been approved for use in the US. Most of them are in spec, but notably several applications with gallium-68, which are also related to PET, and the PSMAs, as I said, gallium is also approved like a week ago for the US. And this is just the beginning, not the end of the story, because as we know, there are several more traces which are out in the field, and we are basically are entering slowly but surely the clinical routine. Quite a lot of investment from radiopharmaceutical companies on that as well. So coming into the part of the PET systems, how do we create a system that addresses these needs? So the need of new applications. It is our belief that basically the system has 2 qualities. The first quality is related with the ability to be flexible, so to address different protocols in the field. And the second ability is to maintain the performance irrespective of the protocol that you're using. When we translate this into clinical utility, from flexibility perspective, we are talking about patient throughput and dose. And for the performance perspective, we are talking about lesion detection and quantification. And then when we move one step further into performance parameters, what we need to have into the system in order to enable this basically boils down to two things. The first one is a very good signal-to-noise ratio, and the second is spatial resolution. The difficulty arises here from the point of view that these two parameters, these two parameters are basically non-orthogonal. So, which means that once you are trying to optimize one, basically you are fiddling with or you have negative effect on the other one. So, what can we do to improve this? I make a parenthesis which is very relevant, and this parenthesis is the introduction of silicon photomultipliers into the PET design. They are small, they are very capable, they have very good qualities, but with respect to the size, the main advantage that they brought is scalability. So now the different manufacturers have the ability to offer much easier and faster different flavors of the systems. But for my discussion here, the most important parameter is that it dramatically improves, it has improved the time of flight performance of the system. And time of flight is, without having much time to go into detail into that, is basically the penultimate technology the last years in PET, because it has the ability to control noise that propagates within the reconstruction much tightly. The better the time of flight performance, the more or tighter the control of noise propagation within reconstruction. And also it has the indirect effect that you can also do a much better scatter correction. So now that we have a much better timing performance, basically we are allowed to focus on the spatial resolution of the system and do that without basically compromising so much as before the signal-to-noise ratio. So different manufacturers are taking different approach into this. So presenting what we have done at Siemens is basically the Vision PET platform, which comes into two different flavors. So it's a 20 and a 26 centimeters axial field of view. And what are its qualities? Well, the first quality is focusing on spatial resolution, and we have taken a radical approach into that. We went away from the already small 4x4 millimeters that our other systems have, and we did it even smaller. Now we have LSO crystals that are basically 3.2 by 3.2 by 20. So the inherent spatial resolution of the detector itself is improved. Then these crystals are covered where the light exits are covered 100% by SIPMs. This is a unique implementation in the field today. And of course, we have not also incorporated, or we have not achieved that with using light guides. So we have not used light guides and a quite dense silicon photomultiplier with respect to the crystals that have been used. And why I stress this? I stress this because these are the two main components which affect the timing resolution performance of the system. So the vision systems are able or are achieving a timing resolution performance of 214 picoseconds. The time of flight gain is a gain which is not linear, which means that basically as you proceed, the better the timing resolution you get, the gain that you receive is exponential and not linear. What is this gain? The gain is that you are better fit to localize the event that you are detecting, and in the vision case, we are basically able to localize the events within an area of 3.2 centimeters. And in order to explain or to give you an example of what does this mean, is I have taken a brain scan. A brain scan predominantly has not been affected by time of flight because it's a very small object. So the back projections are very short. and it has very too much structure in it. So, and historically they used very small or much smaller matrices than the 180 by 180 that the vision is using in the standard brain protocol. So what we have done here is basically we have reconstructed without time of flight and without PSF. So the most relevant technology up until now for improving this kind of scans is the point spread function correction. Why? Because you improve the response, the spatial resolution response of the system, of the camera. But in this case, because we have already a very good spatial resolution with the small crystals and with the fine matrix for reconstruction, you see that we are improving a little bit the contrast because of the filtering, and this is the filtering because of the PSF reconstruction, so the convolution. The data on the vision we do not use any post filtering anymore. But you see that in contrast to what we have anticipated, there is blurring. So what we achieve here is basically to essentially blur the original data. If we go the other way and we introduce, we reconstruct with time of flight with the 214 picoseconds timing resolution performance, we see that we have controlled the noise to the level that we now can see much clearer the structure. And on this data, we can then go forward and we can introduce the PSF if we wish, and then we have the full picture and the performance of the system. Now, how does this translate into the whole body applications? Well, as I said, SIPMs gives you the flexibility of creating systems that have equal good quality, and basically you can choose what system fits best in your practice. So here is a whole body scan with a Vision 600, inject activity 100 megabecs, acquisition 60 minutes post injection, acquisition time 3 minutes for the whole of this field of view. If you have the same, acquisition scan on a 450 and you need to keep the injected dose the same, you have to increase your acquisition time from 3 minutes only to 5 minutes. And then on the contrary, if you would like to keep the activity, the 3 minutes fixed also for the 450 vision, then you would need to increase your activity from 100 megabecs to 180. Now, 180, if you remember, is basically half of what we were injecting 10 years ago on standard systems. The other trend that we see in the field is basically the introduction of artificial intelligence into nuclear medicine applications. So here I will give in a very short overview of what we have already implemented into our systems, and not only to the vision, but to the whole range of the systems. So starting with the deviceless gating approach. So yes, we have a deviceless gating approach. You can utilize information from the data themselves to extract the motion fields, the motion management, the motion information, and you can use this information with an optical algorithm which we call OncoFreeze, to create images without motion. But what we have also done is to introduce an additional step here, and this is the alpha technology, which is based on the CT information. The system is now able to define which areas are affected, are likely to be affected by this motion, and the ranges of this correction are basically done automatically. In the same way, Siemens, for the last 10 years or if more, not more, we have the ability, our systems, to not do step and shoot modes, but to do continuous bed motion acquisitions. Again, with the introduction of artificial intelligence, now the system is able to not only do this in one go and implement different approaches to the protocols that you have selected, but now it recognizes also what the body habitus of that specific patient that you have on the table, and it adjusts those ranges automatically. So again, with one press of a button, the technologists can acquire this data for that specific patient. And of course, if you have such a nice technology like flow motion, you can use it also for the other applications. So for research departments, we have developed an application where we use the flow motion to acquire dynamic data. These dynamic data are basically utilized by a sophisticated reconstruction scheme to create automatically kinetic parametric images based on Padlock kinetic model for FDG. Where is the artificial intelligence application here? Well, it's here in this block. So in order to get the arterial input functions of the first pass, the system now is able to identify exactly where the descending aorta and the left ventricle is. It will place automatically the ranges there to get the sampling from the image of the plasma activity. I could not omit here to mention that yes, this is very nice, but if you have the ability to have a system which has a very large axial field of view, and this is another trend that we see in nuclear medicine today, basically you don't need this. And I'm referring to the latest introduction to the Vision family, which is the Vision Quadra. It's a system that has exactly the same technology as the other Visions, but it has 106 centimeters axial field of view and superb sensitivity, which basically enables you to do dynamic studies of the whole body where the organs exist. So from the vertex to the thighs, without basically having to move the table. So now we are able to acquire this very high timing resolution data, and basically it's up to the users of this system to develop new applications. The first two systems, such systems, have already been installed, and we anticipate another 5 to 6 systems to installed in the next month only in Europe. Last slide, I cannot leave you without also mentioning the artificial intelligence in the reporting chain. So up until today, when we had the data were extracted and reconstructed, it would be sent to the reporting physician, and usually what you had to do is to identify which of these lesions are malignant, segment those lesions, and perhaps report SUVs and where exactly they are. So now an artificial intelligence algorithm that has been trained on several thousands of FDG data can do that automatically. It's extremely fast, so it can segment and comment all lesions or all activities in the body within 10 seconds, and it can also classify, or so basically suggest which of these activities are not likely to be physiological to you, to the reporting physician, with an accuracy of 92%. And you are able then to take it on board and basically agree or disagree or correct the data according to your experience. And it will also, after you have finished with that, it will also compile a report that you will review and you will be able to export. And with that, I would like to thank you, and I would like to ask if there are any questions. I'll be very happy to answer. Thank you.